Welcome to Boston Children's Hospital Facebook Live. We are here today talking about functional abdominal pain. My name is Liz Birch. I am a nurse practitioner at Boston Children's Hospital in the Motility and Functional Gastrointestinal Disorders Center. I'm also the clinical coordinator for the Multidisciplinary Functional Abdominal Pain Program. So I'm pleased to introduce and be here with Dr. Samuel Nurko and Dr. Julie Snyder, who are part of our abdominal pain team here at Boston Children's. So Dr. Nurko, please introduce yourself.
Yes, hi, welcome everyone. My name is Samuel Nurko. I'm a pediatric gastroenterologist, and I'm, one of the physicians in charge of the abdominal pain program. And as you heard, it's a program, so we have a multidisciplinary approach. So I want, Dr. Snyder to introduce herself.
Hi, good afternoon. My name is Julie Snyder. I'm a pediatric psychologist and the director of the GI Psychology Service at Boston Children's Hospital and a psychologist in our multidisciplinary abdominal pain clinic. Happy to be here today.
Thank you. So just first of all, kind of kick off with introducing us as a team. And so we mentioned a little bit about this multidisciplinary FAP team, but Dr. Nurko, can you just sort of explain to everyone what the team is and sort of who we are and what we treat?
Yes, so, our multidisciplinary team came to be because patients that have this chronic abdominal pain, are and deal with a lot of complexities in their day-to-day treatment, right? And even though you are talking to a gastroenterologist, we all understand that the pain is not only the stomach. The stomach is within a person, and the person lives within a society and has to function and go to school. So knowing that the person is not in isolation, we created this team because we understand that you cannot separate the patient in little pieces, and you need to look at the patient as a whole. And our team is based on that then. So you have a gastroenterologist looking at what are the reasons for the pain, what are the triggers for the pain. We have a pain specialist that deals with how can we modulate the pain, what medications can we use. We have psychologists that look at, okay, what's the brain role in this, what's the emotional role, and how can we help the patients go better with the pain. We have a nutritionist that deals with what are the triggers of the pain related to the food. And then we have a social worker that helps us, reintegrate patients to life and to school. And finally, we have the director of the orchestra, which is Liz, which is, our nurse practitioner that coordinates everything and all the different pieces. And we draw from many specialties. Again, we don't look only at the abdominal pain. Many of these patients have other reasons for the pain. So we work with neurologists, rheumatologists, infectious disease, other specialties that have an influence on how the pain is interacting.
Thank you. So I think this is a great kind of jumping off point to explain sort of what is functional abdominal pain. We get that a lot. We've had some wonderful questions already posed to us, and I think it would be helpful just to kind of start off and explain what is FAP.
Yeah, so functional abdominal pain is a term that has been coined through the years. I want to say that most of us don't like the actual term of functional abdominal pain because the first thing that the parents and the patients get is the message that this is not real. And we are trying to get away from that. So the new terminology that's being used now is disorders of the gut-brain interaction, because they reflect exactly what's happening, right? So the abdominal pain we're talking about is a chronic pain that's related to obviously the GI tract and how that has interacted with the brain. And the way we conceptualize this, just to be more specific, imagine we're talking about a pain that's like a software disorder. So if you look at a computer, what's not working is not the hardware, it's actually the software, is the way things move and the way things are being perceived. And more importantly, because it's chronic pain, we're talking about a pain that's really hurtful, but is not harmful, right? So these disorders, unfortunately, because usually there's no hardware problem and there's nothing harmful that people can actually see and take out or give medication for, are then considered like they are not real conditions and everything is in your head. And there's nothing farther away from the truth. The pain is real, but it's a software issue in a hurtful way.
And can you explain a little bit about this framework we talk about a lot in our clinic? It's called the biopsychosocial model. Can you give us a little background on what that is and how that relates?
So what Liz is referring to, and it's very important, is these diseases like chronic abdominal pain, and I'm gonna just expand it a little bit. The abdominal pain that's chronic can come in different flavors, and depending what other GI symptoms you have, we give them names, right? So if the abdominal pain is related to bowel movements, we call it irritable bowel syndrome. If they're related to abdominal pain in the upper part or nausea, we call it functional dyspepsia. If they have other characteristics, we may call them migraine. And when there's no other associations, that's when we call it abdominal pain of the functional type, right? And these are the same diseases. It's just the manifestation is a little bit different. So the important part is if you follow what I said, usually it does not follow the typical medical model that a lot of you must be aware of. If I have a sore throat, I do a throat culture, it's positive for strep, I get penicillin and it goes away. This is an acute medical model. That's not what these diseases are. These diseases tells us that the disease is happening in a person, that the person is experiencing the illness in its own way, and there's genetic predispositions and coping mechanisms that are the ones that lead to the development and chronicity of the abdominal pain.
So a couple of questions have come in already, and so thank you, everyone. A lot of them are questioning around diagnosis and how you actually diagnose a functional abdominal pain disorder. Specifically, one question that was sent in is, quote, I would love to know how physical symptoms that might be connected with the brain are sussed out as opposed to another reason for those symptoms.
Yeah, that's a very important question because the biggest issue we see with the families all the time is, what's wrong with me and what are the tests you have to do to uncover the disease, right? So abdominal pain disorders or disorders of the gut-brain interaction are really disorders that do not need any testing. The disorders are symptom-based, and that's what makes it very complicated. In many areas, you know, when you talk about a migraine, people accept the diagnosis of migraine. Nobody wants to do a brain biopsy for the migraine. In diseases like schizophrenia, depression, again, nobody wants to do a brain biopsy to see it. So people accept this symptom-based diagnosis. So abdominal pain disorders of this type are the same. They are symptom-based diagnoses, but because there's so many organs inside the abdomen and so many diseases that can give you acute problems, people are reluctant to agree that this is a software problem and that we don't need any testing and that the testing is going to be negative when we're trying to diagnose this. So it's a symptom-based diagnosis. Yes, there's alarm signs that we physicians use to decide when do we have to investigate more to be sure there's no triggers of the pain. That's another concept. It's not the reason for the pain, but triggers for the pain. And then we may do some testing looking for those triggers, but then really we don't need any major testing to do that. And the most important thing, this pain is real. I just want to stress that. The pain is real. It's not psychological. So everybody looking at this table is going to say, okay, what is Dr. Snyder doing here if it's not psychological, right? And I'm going to let her explain what's the interaction, as Liz was asking, between the brain and the gut, and why do we have a psychologist, even though this is not psychological.
Yeah, thank you, Dr. Narco. And so he's absolutely right. The reason, and we always explain to our patients and our families, is that, you know, one of the things I always emphasize is that, yes, I am a psychologist, but I'm not seeing you because I think that your symptoms are all in your head. What we know is that there's actually evidence to support the use of psychological strategies to change the way that your brain perceives what's happening in your stomach or in your belly. And we know there's a bunch of different strategies that a person can use to be able to manage those symptoms. We also know that a child or an adolescent's perceptions of their pain symptoms or their ability to cope or their difficulties with coping can really influence the significance or exacerbate the symptoms at times too. And so as a psychologist, we help patients recognize what are their coping strategies, what are the strategies that we can help them learn to turn down the volume of that pain that Dr. Nurko is mentioning and talking about, about? And most importantly, how can we get them back to life and functioning? How can they use these strategies? And just another point is, when all that becomes is that you're thinking about the pain all the time, we call this catastrophizing, right? They're constantly thinking about this. And we know that that constant thought process around the pain, or am I going to be able to cope, can it also exacerbate? And so helping patients to change their thought patterns around it is also important.
Julie, thank you, Dr. Snyder. It's actually timely that you said that, because we've had a lot of questions have come in really directed towards you. And one, I think that, someone wrote is something we always hear in clinic. So I just wanted to kind of put that back out to both of you to touch upon. Somebody wrote in, my daughter has been told that the pain is all in her head and to see a psychologist. She feels discouraged because she doesn't think anyone believes her symptoms. Do you think that abdominal pain is caused by anxiety? And that's directed towards you, Julie.
No, abdominal pain is not caused by anxiety. But what we know is that when patients become anxious about their symptoms, right? A patient who's going to the bathroom multiple times a day and all of a sudden is thinking about, will I be able to go to my prom, or will I be able to stay in school with these symptoms? That naturally would create anxiety for anybody. So when the anxiety is there about the symptoms, or sometimes patients present with anxiety about other things that are going on in their life, it doesn't help, is how we explain it. So Dr. Nurko used that message of we look for triggers, and oftentimes a patient's mental health symptoms may be a trigger that exacerbates the pain, but in no way, shape, or form does a mental health symptom cause this pain to happen or occur.
Yeah, then I'm going to take the other approach. You see, do we have any evidence that the pain is real? Right? And that's hard to do because pain is a subjective experience, and we are nobody to decide if somebody that's, having horrible pain, if the pain is real or not. In our mind, every pain is real, and every patient perceives the pain in its own way. And that's this biopsychosocial model. Now, having said that, people like myself have been very interested in trying to see, okay, is there any evidence physiologically that the patients have more pain? And the answer unequivocally is yes. So there's different types of things that we know. One of the big symptoms that's happening is what we call hypersensitivity. What does that mean? Or hyperalgesia in the case of the visceral, right? What this means is that things that should not be painful become painful. It's not normal to have food cause pain when you eat, but these patients have pain when they eat. That doesn't make the pain less real. What we know is if you do studies, the hypersensitivity means that things, as I mentioned, that should not be painful become painful. Imagine a sunburn, right? When you are sunburned and you touch your skin that's red, it's going to hurt a lot. Once this heals, the same touch doesn't give you pain. So people have shown, it's not a burn, but people have shown that the nerve sensitivity of the stomach or the intestine is heightened when you have these conditions. So just to give you a simple example, so if somebody would need a very big volume of poop to feel that you have pain in the intestine, like 200, just to give a number, patients with abdominal pain may need only 20. So the pain is the same, but it's triggered by less. And then we've done studies, and other people have shown also, that the pain starts to change your brain function, not structure, but function. So if you do functional MRI, the areas of the brain that feel pain have been shown to be increasingly lighting up and working in patients with pain. And patients, the circuits that make you aware of the pain and make you control the pain also have abnormalities in these patients. So if you think about the software, you feel more pain with less, your brain feels more pain with less and is more aware of the brain. And then yes, and this is also truth, if you are anxious or you are fearful of the pain, that makes the pain worse. So there's no question that your emotions have an influence on the pain, but they don't cause the pain. And the first concept, again, I mentioned it before, the pain is absolutely unequivocally real.
Yeah, and one of the things I always like to say as well, and we talk a lot to our patients, is that pain is hurtful, but it's not harmful. So I think it's really important that if everyone's out there listening, that the one concept you take home is that your pain is real and it is hurtful, but it's not harmful. There's nothing bad that's happening inside it. We acknowledge that the symptoms are real, but we're not concerned that there's something that's underlying that needs immediate attention. And so that leads me sort of, Dr. Nurko, to my next question. is can you talk a little bit about sort of the treatment and how we treat patients who have these types of disorders?
There's many ways to frame the treatment, right? A lot has to do with the messaging, and we see patients that have seen many, many doctors before they come to us, right? So the first thing is you have to trust that we've done a very thorough review of the patient's case, the patient's whatever testing they've done before, and the clinical presentation for me to be sure that what they have is a symptom-based diagnosis, right? And that's very important. So once we tell you the pain is real and the pain is the illness, that means we've already reviewed all the evidence and we know and understand that no more testing is going to give us the clue, right? So we don't do testing to see what's causing the pain because all the tests are going to be negative to the point that we find patients that have had multiple x-rays, CAT scans, surgeries, colonoscopies, endoscopies, and it's always negative because people are looking for the reason for the pain when the pain is the disease. So that has to be communicated in the visit and in the understanding. And then the next question is, if you followed what I said, we may do tests to look for the triggers of the pain. Are there any specific triggers of the pain? Is the patient constipated? Are there any specific foods that are triggering the pain? And then if you think about a tricycle, that's an analogy that has been proposed. The treatment of the pain has one of the wheels, each one of the wheels represents a part of the treatment. So one wheel represents the portion of looking for the triggers. What can we do with the pain? Do I have medications to decrease the pain sensitivity that these patients have? The next wheel is the psychological approaches, as Dr. Snyder told you, to try to tone it down, coping with the pain. And the third wheel is physical therapy and rehab, going to school and functioning. We push very hard to function. You cannot wait until the pain is gone before you function. And if you do an analogy with acute pain, like if you have an ACL rupture and then you do physical therapy to walk, it hurts a lot to do the physical therapy, but you keep walking and eventually it gets better. So the short answer is you need the three wheels of the tricycle to function. It's not only medication, it's not only physical therapy, it's not only the psychological therapy. You need the three aspects. Not everybody needs everything, but in general, you need to be cognizant of these different tools.
And we had a great live question come in. So Dr. Nurko, this mother asked, my daughter has been nauseous for about 5 years and was recently diagnosed with functional dyspepsia. Any recommendations?
Yeah, so this, as you know, we cannot specifically recommend specific treatments, but I can tell you nausea is one of the most common symptoms we see in these patients with software disorders. I also would tell the mom, and we empathize with her, is one of the most difficult symptoms to cope with because it's lousy to feel nauseous all the time, right? So functional dyspepsia is just the same name. But again, there's many ways to treat it. You need to look for, are there any specific triggers for the nausea? Can we tone the nausea down? And there's medications that have been designed that change the way your stomach feels the nausea and your brain feels the nausea and the way your stomach works. And then there's psychological techniques to try to tone the nausea down. So yes, there's a lot of techniques to be able to see, but it's very important to understand that there are any specific triggers that need to be, dealt with.
And Dr. Snyder, any specific things you wanted to mention just about nausea in particular? We know that can be a very challenging symptom that our patients struggle with.
Yeah, and the same strategies that we use, the non-pharmacological strategies that we would use to treat functional abdominal pain, we know is also helpful for functional dyspepsia. So we know that, really addressing that over or hypersensitivity of the nervous system, learning different relaxation strategies or techniques. There's some evidence for the use of clinical hypnosis for the management of these types of symptoms. So it really falls, in a similar category, and the arms of treatment can be similar.
Thank you. So kind of coupling on what you've been talking about, we've had a couple questions come in about school and symptoms at school. And again, that's something that we hear a lot. And it's, one of the reasons we have social work and psychology involved in our team. And so this question, I think, really is a good one for us. It says, my son has missed a lot of school because of his abdominal pain and GI symptoms. It is really hard for me to force him to go to school when he feels sick. However, he is falling behind in classes and the school keeps calling me about his absences. Does your team have any experience with this?
Yes, we have a lot of experience. Many of our patients who experience this abdominal discomfort do end up missing school. We know notoriously school mornings are difficult. Our patients tend to not feel well in the morning times. And our goal is to try to get patients back. Going back to Dr. Nurko's conversation, the symptoms are hurtful, but not harmful. So we know that they may not feel their best in the morning times as they're getting off to school or at a certain time in the day, but we really want to encourage that return to school. If your child is a child who's been having symptoms for just a short while and has been out of school, we want to reintegrate them back full time very quickly. If your child is a child who's been out of school for a long time because of symptoms, we do a careful reintegration approach with the help of our social worker, where we do a stepwise, maybe little bits of time in school every single day to work up to a full-time schedule again. But the bottom line is we really would like to encourage the functioning at school.
Yeah, and I would just add, if I may, two other things, right? So we communicate with the nurses all the time.
Mhm.
We do a lot of education of the nurses because, of course, people see kids with a lot of pain at school and they want to be sure, oh my God, this is harmful. Why don't you call the emergency room, right? So there's a lot of back and forth and education that we work. And I can also tell you there's a lot of tools in our toolbox that may mitigate the intensity of the symptoms once they happen at school. So we also work with the school for the patients to try to have, what else can I do to mitigate the symptom when it's happening, and what do I have to do to be able to stay in school, as Dr. Snyder was mentioning.
And just to add on to that, I think, if you're catching our drift, we really work so much as a team, because this is truly a team effort to take care of children who have these abdominal pain issues. And we really look at it as like a rehab approach, right? Like rehabilitating you back into your function, back into the things you love, your school, your activities. And so, that's why we sort of talk about the functioning first, even with symptoms. So, another question that came in was sort of, I feel like I can't, have my daughter go back to school if she doesn't feel well. And that's a common theme we run into. And our studies even show that the functioning comes first, followed by pain. So you've got to function and then the pain follows. It's sort of, we oftentimes say, like, if you tore your ACL or you hurt your leg, you'd go back to physical therapy and you'd learn how to walk again, even if it hurt. And so you wouldn't wait for the pain to go away before you were to walk again. And so it's a similar philosophy that the pain is hurtful, but it's not harmful. And we want you to get back to functioning. And with time, the pain gets better, but we want to work on that functioning piece first. And so just another live question. I know we're kind of getting close to the end here, but I did want to answer this. This came in on Facebook. It says, my son has severe stomach issues his whole life. He missed most of his childhood education, nausea, vomiting, pain after eating. We've been focusing on gut health and recently added some digestive enzymes. Are we on the right track?
Yeah, so again, just in general, looking for the triggers, yes, sometimes certain foods are triggers. We use a lot of complementary medicine to help also. I mean, probiotics, there's other, things that you can get. So it's very important to rehab the patient to be able to function better, right? I cannot comment specifically on your child, but if there's non-traditional medications that are working, that are not harmful, then we say we encourage that use as long as you work, in getting him back to school.
All right. So there's a couple more questions here. I have one for Dr. Nurko. It says, my son has been diagnosed with irritable bowel syndrome. He also suffers from headaches, dizziness, and has trouble sleeping at night. Do you see patients who have other symptoms in addition to their abdominal pain?
Yeah, that's a very important question because, as we mentioned before, this is a software disease. And if you go back to the computer analogy, is the central operating system is what's not working. So when your computer goes into limbo, the Word program, the PowerPoint, the Instagram, nothing works. So the same is here. Once the disease becomes more severe and your brain learns how to have more pain, we say it's sensitized to have pain in a central way, meaning in the brain, it's very common for us to see overlapping pain conditions. So it's very common for us to see that the patients suffer from many other things like migraines, joint pain, POTS, other things that are associated with this. So the short answer is yes. We see the patients, it's the same disease. It just manifests, in different organs, and the treatment is the same, actually.
All right, I'm going to ask one last question to the group, and I think it's a great one to end on. What is the prognosis of patients who have functional abdominal pain, and will they get better?
Yeah, the good news is the prognosis is great. Most patients outgrow this and they do better. And then we teach them lifelong, ways to cope, to be able to deal with some of the things that may happen. But overall, most patients do well. So we don't like you families or children to be all despondent. There's nothing I can do. Nobody can help me. No, we would not be in business if that was the case. And, we do have this multidisciplinary clinic. Obviously, to see the whole team, we reserve that for the kids that are much more severely affected, right? And that's when you see the whole team. But we see a lot of patients that do not need the whole team, that, some minor interventions can help. But the bottom line is the prognosis is good.
Thank you. And so I just wanted to thank Dr. Nurko and Dr. Snyder, of course, for being here and chatting with us. If you can't tell who are listening, we could probably talk about this for hours. This is sort of what we live and what we do and what we love. And we love taking care of our patients with these disorder. And we really just enjoy our team and our work. And just thank you so much for tuning in. So we're going to have our website posted in the chat. If you have any other questions or information, feel free to look at more about us at that point. And thank you again for joining in. Thank you, Dr. Nurko and Dr. Snyder. Have a great day, everybody.
Okay, bye.
Bye.
Bye.